several public healthcare facilities have made headlines for all the wrong reasons lately, but there's at least one institution that has every reason to celebrate. The Steve Biko Academic Hospital in Pretoria has been internationally recognized for its stroke care facility. The institution is the first in the country to receive the World Stroke Organization Angel's Diamond Award for its commendable work in acute stroke care. For more on this, let's bring in the head of neurology at the hospital. That's Professor Mandisa Kakaza, who's with us in our studio here in Randburg. And it's so lovely to have you on the program. Thank you so much for making the journey to come speak to us.
Thank you for having me.
It's such a relief, for lack of a better term, to have something which I think has always been there, pockets of excellence within our public healthcare facilities, especially because there's so much that goes wrong. Let's begin by just understanding the work that you are doing. Acute stroke care, what does that entail?
The acute stroke care means that we should be able to recognize a patient with a stroke as quickly as possible and offer them the best possible management, because we must always remember one thing: time is brain. Which means that if the longer we wait to treat the patient with a stroke, the more brain tissue gets lost.
Right.
So we must try and recognize them early and treat them as early as possible.
Yeah, as is the case with many ailments. Cancer, for instance, is another example.
Yes.
How prevalent are strokes in this country? Because you always sometimes get a sense that there is an upward trajectory, and if that is the case, do we know what's causing it?
It's actually a very interesting thing in that if you look at the developed countries, there's a downward trend in stroke incidences. But if you look at the developing countries, there's an upward trend. So because it's one of those conditions that we refer to as non-communicable diseases, right, that are now on the rise. So it is the same with us. For instance, if you look at our statistics, you will find that if you look at developed countries, for instance, someone is likely to have a stroke when they are in their 70s, well above 60. Whereas when we looked at our stats recently, we found that a lot of our stroke patients were in their 40s. And one of the commonest causes for that is these non-communicable diseases that can cause stroke. For instance, things like hypertension, things like diabetes are leading causes that are diseases that often lead to someone having a stroke. Okay, and these are the conditions that we need to look at and we need to manage to prevent. So these are two different messages. One message is to prevent before the stroke happens. Once the stroke has happened, what then do we do in the tertiary hospital to manage these patients as effectively as we can?
Yeah. As we still understand the context that we're working in, is there a split when it comes to whether or not males or females are more prone to be getting strokes, according to your statistics, by the way? Because, again, typically what we hear is that men don't really take care of their health, and that leads to a build-up of all these illnesses.
Yes, no, we do see a lot of men who present with strokes. Yes, because, as you say, men are not the type who are going to go for a checkup every 6 months to see if the blood pressure is high. They will walk past the pharmacy without checking the blood pressure or just doing a finger prick to check the glucose. The only time they present to the hospital is when things are really bad.
Yeah,
yes,
absolutely.
So we do tend to see a lot of male patients with a stroke.
Well, you're doing something right, because the Angels Initiative, which I'm hoping you'll be able to just give us a snapshot of about what they do, has recognized you with this award. I should have started by saying congratulations, by the way.
Thank you very much.
So tell us about this initiative and, what their objective is in the work that they do.
Okay. So the Angels Initiative, they are not neurologists.
Right.
Okay. So, but what they do is they assist the healthcare facilities in managing stroke patients. So their interest is in the management of the stroke patients. So what they will then do is they will come to the facility. They've got people who actually assist in the training of the healthcare workers within the facility. For instance, they would help us to train the junior doctors to recognize strokes. They would help us to train the nursing personnel to recognize strokes, and help us to just set up our facility to be, ready to treat stroke patients. And once they've done that, they also have a second part that they do, where they actually assist us now to collect our data. So we have a database, and it's a beautiful database. It is POPI compliant.
Right.
Yeah, so that no one's particulars will ever leak. But we are then able to look back at the data and be able to see if we're improving or not. Like I tell you now, we recently looked at our data, and that's where we saw that a lot of our stroke patients are actually in their 40s, which is something that we will need to correct in the future. So they help us in these two main things, is to train the staff, make us stroke ready, make us ready for the treatment of stroke patients, and also in helping us to monitor our data, so that in time we can publish the data, and we have research papers.
Sure.
And yes.
When we speak about being stroke ready, what typically does that entail? Because there's questions around equipment. I'm not sure if you use any equipment. There's questions around skills. Yes. There's questions around personnel, actual capacity to deal with those patients. Is it any one of those things or a combination of all of them?
It is a combination, because let me tell you, I am a neurologist, but I could never do this alone. So part of being stroke ready was that we had to form a collaboration. We had to work with the emergency unit, what used to be called the casualty department. We now call it the emergency unit. So we had to talk to Professor Engelbrecht, who is the head of the emergency unit, and assist with the training of the staff, the junior doctors who run the emergency unit, the nurses who run the emergency unit, because that's where the patient is going to be received first.
Right.
Yes. And then from there, we needed to again have another collaboration with Professor Lockhart, who is the head of the radiology unit, which is now where the scans get done, so that when the patient comes in, the patient is quickly recognized as having a stroke in the emergency unit, and then very quickly the patient is shifted to the radiology unit for the CT scan, and then the neurologist is also involved then to assist with the interpretation of the scan and then the further treatment of the patient.
Yeah.
So it's a collaboration. We need the personnel, but we also need the machinery. So we are very lucky at Steve Biko. We have 3 CT scans on the premises, which means that it is possible for us to have a scan as soon as the patient arrives.
Which is crucial,
Yes,
in a context where it's a race against time. And we know those CT scans can be very expensive, by the way,
Yes.
especially in the private sector.
Yes.
I started our conversation by speaking about there being pockets of excellence. I wonder how unique the situation at Steve Biko is when you look at how prepared we are across the country to actually manage strokes, given those challenges, that we all know about.
Okay. We all know government sectors have got limitations. But sometimes it's not a case of creating something new or buying more expensive equipment. It's actually utilizing what you already have and just streamlining. Because to start the stroke unit, we already had the 3 scans. So the 3 scans are not new. We already had them. We already had personnel, which is not enough, but there is personnel in the EU and personnel at neurology and at radiology. But we needed to just streamline it to make it work better. That's what we needed to do. For instance, I'll give you an example. If you come to the emergency unit, especially because government sectors are so inundated with patients, the chances are, if you are not bleeding, you would have been put one side.
Yep.
And if you are bleeding, you would have had priority. You see. And this, which is one of the reasons why the word casualty is not a good word. Yes. Yeah. So, but now we had to change our mindset and realize that just because you are not bleeding doesn't mean you are not an emergency. Even the patient who's not bleeding is an emergency. And how do we recognize that patient who is not bleeding, who needs to be treated as an emergency? So all we did, with the same number of, we didn't employ new people. We just changed the system, streamlined, got training from angels, retraining of all the staff so that we can, and we improved. For instance, if you look at our stats, before with this training, you could arrive in the emergency unit and it would take a minimum of 8 hours before you get a CT scan.
Minimum
of 8 hours before you could even get to a CT scan. But with this streamlined system, if you come into Steve Biko with a stroke, you will have a CT scan within 15 minutes.
Oh, thank goodness. Because, a minimum of 8 hours is unthinkable. You speak about early detection.
Yes.
What is ideal, of course, is to be able to pick up the signs even from home.
Yes.
And I wonder whether or not people are equipped with that kind of knowledge. I certainly, full disclosure, wouldn't be aware of where to start looking if I want to ascertain whether someone is actually suffering from a stroke.
Okay. There are 2 things that one needs to look at. There is something called a transient ischemic attack, which is a TIA, and there is something called a stroke, when the patient has a stroke. So the transient ischemic attack is where they get deficits, but these deficits are transient, and they actually go away in most patients within 20 minutes. But what's important with those deficits is that they can come back as a full-blown stroke. Okay. It's much easier to recognize a stroke than to recognize a TIA and realize that it is actually a warning of a more ominous event that will come. So the things to look for instance, will be the commonest. Someone has got weakness of the face, the arm, and the leg. Okay. If you wake up in the morning or you're standing doing something, suddenly patient falls down and they've got weakness of the face, the arm, and the leg, usually without loss of consciousness. Okay. That you must be recognized as a stroke and the patient must be taken to hospital. If, for instance, someone suddenly gets a change in their voice, like what we call a dysarthria, not a flu, not a sore throat, but where they struggle to articulate words, sometimes they struggle to find words, those patients often have a stroke.
Is that like a sensation with the tongue? Is that more neurological?
It's a neurological thing that leads to them having difficulty to move the tongue and to move the muscles in the mouth. So now they can't articulate the words. Sometimes, it affects the left hemisphere, the left side of the brain, where the patient wants to talk, but they can't find the words that they need to use. And it sort of happens suddenly. Okay. And sometimes they can have symptoms where it looks like they are going blind on one side. Okay. And all of those, or sometimes it's not weakness per se, but it's numbness, where they say this one side suddenly cannot feel well. But what is interesting about strokes is that it's not something that generally develops over a long period of time. It's something that in most cases will happen suddenly. Okay. So if someone, for instance, tells you that, since 2 months ago I've been having this difficulty walking and it's getting worse and that's not a stroke. You are worried about something that is coming on suddenly. It might come suddenly, go away, come again suddenly and go away, in which case we call it a TIA. But if it can come back, it can come and stay, then we call it a stroke.
Sure. Okay.
But what is very important is that the main problem that we are talking about is that we have two types of strokes. We have a stroke where the blood vessel gets blocked, which is the ones that we're talking about today mainly.
Yes.
The ones that was. But we have also another stroke where the blood vessel bursts and they bleed into the brain. That's a different type of stroke. So the one that we are talking about managing now is the one where the vessel gets blocked. And when it gets blocked, it causes death of a small area in the brain.
All right.
But if you leave it, if you don't treat it as an emergency, that area of brain that is dead gets bigger and bigger and bigger.
Sure, and that can lead to...
That's where the urgent treatment becomes important.
I think this information was very important. Thanks very much indeed for breaking it down for us from someone or a team that's been internationally recognized for the work that you're able to do in treating strokes. We really do appreciate you coming in. And once again, congratulations on the work that you've been able to do.
Thank you very much.
All right, there you have it. Professor Mandisa Kakaza, who's the head of Neurology at Steve Biko Academic Hospital, helping us understand some of the work that they've been able to do when it comes to treating strokes, being recognized there by the Angels Initiative.